Hello all, in our last video we just discussed about the geriatric rehabilitation and some of the problems that are facing during the aging. Okay, what are the changes? So that is a nervous system changes, musculoskeletal changes during aging. These are all we discussed in our last video. In this video we are going to talk about the principles of the geriatric rehabilitation. In this, three main principles are there. In first principle, variability of aged. What is variability? Which means they are different. Okay, so they are more variable in their level of functional capacity. Okay, functional skills. Okay, so there is a difference. Okay, can be identified not only as a motor as well as cognitive. Okay, so these like differences are we can note. So here we are not focused on the chronological age. Okay, we are focused on the changes. So chronological age is just one single indicator. Okay, but it is a poor indicator. It does not going to define the changes. Okay, but the variabilities. So it is an important consideration during the geriatric rehabilitation. Some of the examples of the variables. So start with reaction time. So the geriatric client, the reaction. Okay, so if we are giving one command, what is the reaction time of their brain? So that is one variability. And the visual capabilities. Okay, some person may have the blurred vision like that, and the strength, their muscle strength, and their cognition. So these like variabilities we are going to note. Okay, so by these the principles of the rehabilitation are used. Okay, so this is the first principle. Then come to the second principle, that is the activity or inactivity. Okay, what is the common reason for loss of function? So obviously we can tell if we lose a function, that is there is somewhere inactivity or immobility is there. Okay, immobility we can divide this into two: acute immobility or chronic immobility. Okay, so the immobility may produce some of the results to the client. Okay, so we have to deconditioning the result from the immobility, which means normal condition is impaired in the immobility patient. So in which area? So neurological area, cardiovascular area, and the musculoskeletal area. Okay, so in this area the normal condition is impaired. Okay, so third principle is optimal health. Optimal health means there is a required amount of health should be having in that person. Okay, okay, so the person with the geriatric having a geriatric population having higher disability. Okay, which means some persons may have the speech disability, some person may have the hearing disability, some person visual disability, some person having agility. So these like disabilities are coming to the geriatric population. Okay, so surveys are taken. So how many people are having these like this and all. Okay, so these are all having in the research. Okay, due to aging, what are all the obstacles, okay, they are facing during the performance of activities? Okay, first, process of aging itself. Okay, it is one of the obstacles. Then effect of inactivity. So when come any disease, the person becomes the inactivity, so it leads to disease again. So inactivity lead to disease, disease lead to inactivity. Okay, this is cycle again. So it's going to gradually affect the process. Okay, the performance of the client. Then challenges in relationship. Okay, or any physiological decline or functional loss. Okay, these are all combined and it are going to affect the performing activities. Okay, so we can conclude there is an inactivity. If there is any immobility, okay, so it's going to be problem. Okay, so if the person is having the bed rest, then it is a problem. Okay, so immobilization accelerates the process of aging. Okay, so we can tell use it or lose it. Okay, if we are doing the bed rest, what are all the problem we may face? First, B stands for bladder and bowel. Okay, bladder and bowel incontinence, bed sores will come. Okay, bed sores. B stands for this. If we are in the bed, then we may have the emotional trauma and the electrolyte imbalance. Okay, if we are in the bed, we have the we cannot have the normal condition of the muscles and nerves. Okay, that's a deconditioning. Okay, and a demineralization of bone or that. Then come to the R, bed rest R. Then we may have the range of motion loss, contractures, restlessness and all. Okay, E stands for energy depletion. Yes, for sensory deprivation and sleep disorder. T stands for trouble. Okay, so this is all about the principles, that is immobility and optimal health. The WHO also defines what is our health like that. So we can recall it. Then come to the components of the rehabilitation. Okay, what are all the rehabilitation settings? So one organization, that is a commission on accreditation of the rehabilitation facilities. Okay, so they are defined three level of inpatient medical rehabilitation. Okay, so that is rehabilitation for the acute care and hospitals, rehabilitation hospitals. Okay, and nursing home rehabilitation. Okay, as well as outpatient and home health rehabilitation. Okay, home health rehabilitation. So these like levels are there, the settings. Okay, the providers, there is a difference between the master therapist as well as the therapy assistant. Okay, so therapeutic techniques are unique. Okay, there is a difference between the OT and the PT. Okay, there is a difference between the licensed PT person as well as unlicensed PT assistant, like that. Everything is different. Okay, so the rehabilitation process having in various settings, the various providers are there. Okay, okay, we already talked about the inactivity. Okay, so activity may lead to the normal rehab process. Okay, so we can give the exercise for reactivate the muscles and reactivate the nerves and reactivate the cardiovascular functions and all. So we can tell regular physical activity can enhance our life. We can classify the exercise in 5 categories. Okay, that is a resistive exercise, aerobic exercise. Aerobic means we are going to do the high endurance. Then balance exercise, flexibility exercise, and a functional based exercise. Okay, so these like exercises we are doing. So resistive exercise having an impact in the older person, including sensitivity, insulin sensitivity, okay, bone mineral density, and aerobic capacity and muscle strength. These are all improved. Okay, when come to the aerobic exercise, that is a endurance exercise. Okay, so it is going to prevent the diseases. Okay, examples, stroke is coming in uncontrolled hypertension. So these like disabilities can be prevented by the endurance. Okay, we then come to the balance training. Okay, so it lead to the prevention from the fall. Okay, so fall prevention techniques or talk to the client so that they can protect their joints. Okay, they are wearing the hip protector for 2 years. Okay, some of the postural things they are doing. Then come to the flexibility exercises. We can tell is as range of motion. Okay, so normal range of motion is deprived. Okay, so their flexibility is affected. So for that, some of the flexible exercises are given. Then functionally based exercise. So it is given as a task based activities, task based resistive, task based aerobic, task based balance, like that. Task based activities are given so that they are functional. They are doing in their daily life, that is a functional, so that like activities are improved. Then come to the adaptive and assistive technology. Okay, the for people without disability, these technology make things easier. Okay, but for the disabled people, technology makes things possible. Okay, like these quads are there. Okay, so assistive and adaptive technology according to the client is used. Okay, so we have various assistive technology, adaptive technology we are going to discuss in our further videos. Okay, so I'm not going to talk about this in this video. We are going to talk about the palliative care. Palliative care, so it is derived from the word pallium. Okay, meaning cover. Okay, so in this we are going to cover. Okay, so we are going to, if the person having any threatening illness, which means um, threatening, life threatening illness. Okay, so we have to relief of suffering, so their suffering is going to be relieved in by us. Okay, and we can try to prevent. Okay, so by means of early identification, assessment and treatment. Okay, even though it is uncurable, we are just make the patient relief from the suffering. Okay, so that is we are going to cover the disease. Okay, the suffering should not be felt by the patient, that is the important goal. So for the palliative care, 7 C's are there. So it is given by the scientists. Okay, so what are the 7 C's? First C is a communication. Okay, during palliative care, communication is much more important. Then coordination, we have to give support and all. Okay, and control of symptoms. Okay, for that we can give the drugs. Then continuity out of hours, we should give the continuous treatment. Okay, then continuous learning. Okay, then care support we have to give. Then dying phase, we have to care in the dying phase. So these 7 C's are everything is a care, learning is a continuity. Okay, so everything is a C. Okay, so these like 7 C's are there in the aging. Okay, okay guys, in this video we just discussed about in our last video we discussed theories in a two main groups, genetic and non-genetic, and changes. Okay, physiological changes. And we just discussed about the major principles of the geriatric patients and components, including settings, providers, intervention, assistive devices, and what is the application of the environment and palliative care and all. Okay, now further video we are going to discuss about more and more topics. Thanks for watching. Tata, bye bye.